Good afternoon, Rudasa members and exec. Myself and Indira will be just chatting to you about some NHI accreditation consultations we both attended on behalf of Rudasa. Just by way of introduction, my name's Adam Asghar. I'm a family physician and have been involved in Rudasa for over 10 years or so. Indira?
Thanks, Adam. I'm Indira Govender. I've also been part of Rudasa for over 10 years. I'm based in KZN. I'm a sessional contracted GP, an NHI doctor at the moment, but also a specialist in public health and epidemiology. So yeah, I'm going to ask Adam to go first since you attended before I did. You joined the session before me, so go for it. And yeah.
Yeah, thanks, Indira. I should also say that I am based in KZN too. So I stepped away from clinical work at the end of last year, and one of the things that I undertook to do was to understand NHI better. And I think one of the things that one of the main things that I've come away with so far in my own journey, which kind of links with this consultation, is that NHI is one possible vehicle for healthcare reform that I think all parties agree need to take place in order to secure equitable healthcare or universal health coverage as the specific term. And so although there's uncertainty about NHI with the Constitutional Court and all of these political wranglings, I think we all have to use the NHI debate and consultation as an opportunity to engage with national government to kind of co-create a vision for equitable healthcare. So yeah, back to specific things. These were consultations specific around accreditation of health facilities, and just to kind of touch on what I understand accreditation to be. So, you know, when you your vehicle, let's say you have a car and it falls out of service plan and you decide to save a bit of money by going to a non-manufacturer service garage. There's this I can't remember what it's called. It's like an institute, RMI. This garage is RMI accredited, and it gives the consumer a little bit of peace of mind to say, okay, this establishment has been assessed by a professional body that maintains that demands maintenance of minimum standards. So I've got peace of mind when interacting with these people. They're not just cowboys, and I think accreditation really allows the same to happen for healthcare, and really it describes a 9-step process by which healthcare facilities or healthcare establishments, let's call them establishments, can achieve that status. And so the call was really focused purely on that. Obviously, everyone, the public, professionals have got lots of questions about NHI in general. This was just about accreditation. And the main brunt of the discussion was, is the draft framework readable? And is the message that is written in the accreditation framework consistent with what the NHI branch are trying to communicate? So it was really a chance for them to check that the document makes sense in the eyes of a variety of stakeholders. And so I don't know the full range of stakeholders, but obviously Rudasa was invited HPCSA, I think SAPRA were on the call that I was on. And yeah, in terms of the relevance to rural practitioners, I actually didn't see a sense of immediate context sensitive, relevant to rural practitioners from the accreditation process itself. And I'm curious to know what you think. Is there something that rural practitioners need to embrace differently about the accreditation process?
No, I also, I got the same impression. There wasn't anything there specific for rural health. I think it was a very general presentation on accreditation. Health establishments is what they refer to. And the goal, the very overarching idealistic goal, is to have every health establishment accredited with the NHI in South Africa, so that also becomes a way in which you can improve access, obviously, because that's what the NHI is trying to do, to improve access. So if you have as many health establishments as possible that are accredited, then people have more access, especially those who are going to be benefiting from NHI. And then those health establishments can be they can claim from the NHI. So that's essentially what I understood. And in terms of meeting that criteria, that is, that's a process that will be led by the Office of Health Standards Compliance, not the national government. So again, we can discuss that, or we can just talk about how this NHI Act and accreditation will work. So yeah, that's what I understood as well.
So the OHSC aspect is only one part of the accreditation. It's referred to as certification. But I think you made a really important point. It's the funding. So if you aren't an accredited establishment, health establishment, you won't be funded by NHI. So there's a sort of incentivization here to say this is going to be the main funding model of all healthcare in South Africa. So in order to be considered for funding, you need to comply with accreditation requirements, and to continue being deemed as compliant, you need to provide data. So that really speaks to migration of everything onto an e-health record. And then NHI will extract relevant data for funding, and also that will reassure them as part of the ongoing accreditation process that this is an establishment that provides quality healthcare. I just want to drop on my screen. So basically this is from the Draft Accreditation Framework, and I won't be able to recall what all 9 aspects refer to, but certification is OHSC, registration is your professional body. So are you registered with the SANC, HPCSA, etc.? Benefits refers to a package of service, and that really, it links in with evidence-informed care. So if you don't align with the standard treatment guidelines or whatever will define the benefits package, you won't be remunerated by NHI for that. Staffing, there must be staffing norms, referral pathways, and I think the others we've kind of touched on. Interestingly, something that I raised is the accreditation process doesn't involve patient or health user voice or assessment. They did acknowledge that and say, in future, this will be something that keys into perhaps quality management. So when it comes to certification, as you said, it will be much like, or it will be, OHSC will be the backbone. I think one of the main messages that I got is for state sector, whether rural or urban facilities, obviously people need to become familiar with the language of NHI, but the compliance with certification and accreditation in general should be supported or managed by provincial departments of health. So I don't think individual health facilities will be sort of hung out to dry. There will be processes to follow, supported and managed by provincial departments of health. And the other thing to mention is that where accreditation is going to be rolled out primarily is in primary healthcare. So your PHC clinics, DHCs, and in private it will be GP surgeries and nurse-run clinics. District hospitals and above will be funded by something, well, it won't be capitation-based, it will be something referred to as diagnosis-related groups. Anyway, I feel like I'm straying too much into general NHI stuff. Yeah. So yeah, just keeping it back to accreditation. I'm not sure if I have anything further to add. I think my encouragement would just be for all clinicians, whether rural or urban, to just recognize, as I said at the beginning, that NHI is a sign that healthcare reform is needed. So engage with the materials that are coming out, critique them, provide feedback where feedback is, feedback opportunities are given.
Okay, so I have a few more technical things to add to that.
Yeah.
So just to start to say also that the accreditation process is, it's referenced in the NHI Act. So in this presentation, we were constantly brought back to Section 39 of the NHI Act, which is the discussion on accreditation. In terms of the process, from what I understood, there's going to be an initial accreditation. And so people will then be given an outcome from that. So let's say the health establishment will get one of three outcomes from this initial accreditation. It's either going to be full accreditation, conditional, or none. And after the initial accreditation, obviously, the health establishment will have some time to, meet the requirements. If they've received conditional accreditation, they will be given time to meet the requirements to achieve full accreditation. And then there'll be, reviews. They'll have to submit information to get to that standard. After the initial accreditation, there will be annual reviews. So even if you have been fully accredited, you will still have an annual review, and thereafter the review period goes to every 5 years. So for the accreditation, there will be a call for applications. So then a health establishment will be able to apply to be accredited, right? And they will be provided with supporting information, and then they need to be verified as well. They might also involve random site visits. So a very small sample of health establishments will be selected for these site visits. Once a health establishment receives accreditation, they will enter into a contract with the NHI Fund, and then there will be compliance monitoring and feedback that is provided to this health establishment. Most information will be about the health establishment will be obtained from electronic medical records. And so monitoring and feedback will be automated. So in terms of these electronic medical records, these health establishments will need to be using the HPRS number, and their electronic monitoring record does not have to be identical to what the Department of Health is using, but it should be something that's compatible and that can be integrated into the systems that the national department is using, okay? So then in terms of the certification, as I mentioned, this will, the Office of Health Standards Compliance will be doing the inspection and certification and, determining whether these benchmarks are being met. And there will be, I think, a full range of health services that these will be gazetted, and there might just be a subset also for leniency. And then, of course, it's going to work on this capitation system. So you will have these registered users at the health establishment, and there'll have to be some form of capitation, which I did not fully understand. So if you know more about that, please feel free to explain. The questions that I asked during this presentation, which is how I understood that the goal is to have, all health establishments accredited. And that's obviously in line with the goal of universal health coverage and access. So obviously, there are issues of quality of care and so on. That is not going to be the national department or the NHI fund that will be chasing after that. That's where it becomes the OHSC. And so, for example, at primary healthcare clinics, we know we have this ideal clinic that is used as a benchmark. So that might be something as well that, again, is used to measure how they meet the standards to be accredited. And I think district hospitals have a different set or different guidance. I also asked about how, there's obviously a variety of health establishments. So for example, a GP practice, which is where rural health comes in, because we probably have a lot more GP practices than we have hospitals, for example, in rural areas. So how would a GP's rooms be accredited? For example, if the GP is not providing emergency services, would they still be accredited? So again, that was something that the presenter from the National Department, Dr. Amilkar, he did explain that there would be different requirements depending on the type of services rendered. So that was reassuring, because I figured, is everyone going to be now scrambling to try and meet these requirements and provide services that they were not equipped to do from the get-go? But I think that's hopefully that's covered. So whatever you are providing, there will be benchmarks for that. I'm assuming that's how it's going to work, and you need to meet the criteria for that. So yeah, that's essentially what I got from the meeting.
Thanks. Yeah, I think I just kind of brushed over that. So I think that was a valuable reflection on like the skeleton of it. Just in terms of capitation, I do believe it refers to a way of reimbursement that is not related necessarily to services delivered. It's a standard fee for provision of primary healthcare services per person that will be risk adjusted, age, social deprivation. And interestingly, I think rurality will also be taken into account to the risk adjustment, because it is recognized that providing healthcare in rural areas and keeping people healthy in rural areas costs more per person. So I think that's the only sort of rural specific capitation thing to consider.
Yeah, I understood it when I read about it in other documents, is that it is a way of, I think, limiting the constant charging of individuals per visit, I think, as you, yeah. But I think that's a discussion worth having on a separate call. It's like, what is capitation? What does it mean? And yeah, how does it work?
Yeah. And maybe actually that's something we can, over the weeks and months, we can actually take on and kind of have these NHI chats and learn from each other and kind of distill the relevant questions, and maybe even invite Rudasa members to submit questions to be discussed, if that makes sense.
Totally. Yeah, I think that would be a very good learning exercise, and also for Rudasa to engage with NHI, because there's a lot of technical terms here that I think sometimes can be intimidating, and in themselves become inaccessible. So we need to translate this into a language that applies to people, since this is about people and health.
Yeah, so everyone needs to understand it, basically. So there need to be interpreters or translators.
Yep. Yeah. Okay, so that's all from me. Thanks very much for this, and hope it's clear. And if anyone has any feedback on this format, please feel free to message us.
Thanks for your time, Indira, and thanks for bringing a different flavor to the to it as well. I think, as I said, you really picked out some fundamental issues that I kind of we need